In this video, we will talk about osmotic demyelination syndrome, also known as central pontine myelinolysis. From the name, you can already tell that it is related to some problem with osmosis, it is related to myelin breakdown, and it is related to pons of the brain. So before we go into the pathophysiology of this condition, let's review some normal physiology of the brain. So, the brain has different types of cells like neuron, glial cells. In the glial cells, we have astrocytes, oligodendrocytes, etc. And the cell, the interior of the cell, and the extracellular fluid, they stay in equilibrium in terms of osmolarity. Now, if you remember, the extracellular fluid has a lot of sodium in it, right? The concentration of sodium in the extracellular fluid is much higher than the intracellular fluid. Now, the cells interior in the brain, they all in addition to these electrolytes like sodium, potassium, calcium, they also have these organic solutes like glutamate, right? So they are also osmotically active. Now, together with those electrolytes and these organic solutes, they maintains the equilibrium with the extracellular fluid in terms of osmolarity. So that is the the normal situation. Now, if a patient is suffering from hyponatremia, that is low sodium concentration in the plasma. Now, if the patient is suffering from hyponatremia, what happens? It means the sodium concentration in the extracellular fluid is going down, right? Now, when that happens, the osmolarity in the extracellular fluid is going down. Now, if the cell doesn't compensate, then the cell's interior is having relatively higher osmolarity, right? So compared to the extracellular fluid, the intracellular fluid in the brain, it is having higher osmolarity in the hyponatremia condition. Now, there is a bad effect to it. A core concept in osmolarity and fluid movement is that solutes attract water. In other words, water moves from low osmolar compartment to the high osmolar compartment, right? Now, in this, if you imagine, there are two compartments now in this figure. One is the extracellular fluid compartment, the other is the intracellular fluid compartment, right? So when hyponatremia happens, the extracellular fluid osmolarity is going down and cell's interior is relatively having higher osmolarity. Now, in which direction water will follow? Of course, water will go from the low osmolar region to the high osmolar region, and that will make the cell, so let's say this is the nucleus, that will make the cell swell. Now, imagine, in the brain there are like many cells, right? So if all these cells start swelling, there will be brain edema, right? The brain volume will enlarge and the brain will herniate, and you don't want that. It could kill. So now, to compensate for this low osmolarity in the outside, now cell adapt to it. Now, how can the cell adapt to low osmolarity outside? It starts to expel these organic solutes out. So, in other words, it will all these organic solutes like glutamate, they will come out of the brain cells. That in that way, the osmolarity inside. So let me show the organic solute outside, and let's remove them from inside, right? So that is what happening, and by doing that, the cell will now bring down the osmolarity of the intracellular fluid. And now they're both, I mean, the extracellular fluid and intracellular fluid osmolarity will come to an equilibrium and cell will not swell. So that is how cell volume will be maintained or cell size will be maintained, and you will prevent brain edema, right? So in acute condition, again, there is hyponatremia outside, and if that, I mean, that can result in brain edema, right? Because cell will swell. But to prevent that, cell will exclude its solute, like the organic solutes like glutamate, and by doing that, it can prevent the edema, right? The extracellular, now in this condition, in this compensated condition, the osmolarity of the extracellular fluid and the intracellular fluid are both are low. Now, if a patient with chronic hyponatremia comes to you, right? So let's say the patient doesn't have any symptoms, and in other words, the brain cells, they have compensated for the hyponatremia. Okay, so that means this patient is having low osmolarity both in the intracellular and extracellular fluid. Okay, now if you are not aware of the fact that you shouldn't correct hyponatremia rapidly, let's say you are a new doctor, medical student, this patient comes to you and you want to, rapidly correct this low sodium level. You want to, you give a lot of normal saline or hypertonic saline, and you want the sodium to go up to normal level, let's say within an hour. Now, what will happen is, in that condition, if you do that, you are giving a lot of sodium in the extracellular fluid, right? So now the condition is opposite. So the cells outside extracellular fluid, that is having now higher osmolarity. Now, think about it. Now the situation reversed. The outside of the cell now have higher osmolarity, but the interior of the cell, it is having low osmolarity as before. It needs to raise its osmolarity. How it can do that? It needs to reaccumulate those organic solutes like glutamate, right? So now the problem is, you cannot rapidly reaccumulate those organic solutes. You need to synthesize them, or take them from extracellular fluid. That takes time. It is not as rapid as as it has to be to compensate for that. So when you suddenly raise the extracellular fluid sodium, it is bringing up the osmolarity in that compartment, but compared to that, there is low osmolarity inside. Now what will happen? Water will follow the solute outside. So that means water will come out of the cells, right? Because it follows the solutes. So the result is cell will now shrink, and these cells will undergo apoptosis, basically cell death, right? And depending on the cell, let's say we are talking about in fact, the glial cells are the most affected and affected first. So if it is an astrocyte, astrocytes are responsible for maintaining this osmolarity. They are very, very important to provide support into the neurons, oligodendrocytes, and when they undergo apoptosis, they lose that ability. When it is oligodendrocyte, right, it can shrink, as I mentioned, in this mechanism, and they are also losing the support from astrocytes. So the eventual result is they will also be damaged. And also that oligodendrocytes are the myelinating cells of the brain, so the myelin will be destroyed. So that is called demyelination. which is in the name of this disease, demyelination or myelinolysis. So that is that will be happening. And if you consider the neuron, they can also shrink. And let's draw a neuron here. So let's say this is a neuron, and we know that the axon is covered by oligodendrocytes. Now I mean the myelin sheath from oligodendrocyte. If you think the neuron will shrink because of this, and they can dissociate themselves from the myelin sheath. So because the neurons also having problem, like they're shrinking, and also the oligodendrocytes are having problems, so there will be dissociation in this interaction. So the eventual result of all of this is due to rapid correction of hyponatremia, the cells will shrink. And if you do an MRI, brain cells will shrink, and if you do an MRI, you will see clearly see the demyelination happening. And that is why in the name it's called, the name has demyelination, but it doesn't mean that only oligodendrocyte or myelins are affected. In fact, astrocyte neurons, they are also affected. Now let's talk about the clinical features and how can you explain those clinical features. So to explain the clinical features, what you need to remember in this is that the pons is the main, the first, the most affected region, and also the region that is affected first. So it is thought that the glial cells in the pons, they have low metabolic reserve, meaning that they cannot accumulate those organic solutes rapidly, because they are not metabolically that fast. So that is why people think that maybe the pons is affected first. And now I list here all the clinical features, and to understand why these clinical features are happening, you need to understand that again pons is the main region affected, and also you need to understand what structures are in the pons. Then you can explain these clinical features. So let's talk about that first. You see here quadriparesis. It means that your upper limb and lower limb, so all the four limbs will be paralyzed. And you also see a pseudobulbar palsy, and they are happening because of the involvement of the corticospinal tract and corticobulbar tract. Let me explain that in this figure. So in the brain is the coronal section of the brain, right? This is the medulla oblongata, this is the spinal cord, this is the pons, and this is the midbrain, and this is the cortex, right? So if we understand this basic anatomy, now let's talk about those tracts. So from the cortex here, right, there are these neurons going from the cortex through this internal capsule into the spinal cord, right? So that is called corticospinal tract. Corticospinal tract, they're the first order neuron that will go from the cortex to the spinal cord, and then synapse with the second order neuron, which will go from the spinal cord to the skeletal muscle of your both upper and lower limbs, let's say, right? So those are the lower motor neuron, and these corticospinal tract neuron, they are the upper motor neuron. And together with that, you have some other neurons which also follow kind of same path, but instead of going into the spinal cord, it will go into the cranial nerve nuclei that are present in the brainstem. So brainstem means the midbrain, pons, and the medulla. So there are lots of cranial nerve nuclei there, and the lower motor neuron are present there, and this corticobulbar tract, they synapse with those lower motor neuron. Let's say here is a lower motor neuron, and the neuron exits here from this nucleus to supply, let's say, muscles of the tongue, right? Or it could be the facial muscles, right? Or pharyngeal muscles. So those are the lower motor neurons, but the upper motor neuron is coming from the cortex to synapse with that neuron. So that is called the upper motor neuron. Anyway, so previously the one that I previously mentioned, coming from cortex going to the spinal cord, that is called corticospinal tract, and those that are coming to the brainstem nuclei, and then brainstem nuclei, that is called that tract is called corticobulbar tract. Now the key point here is that both of these tracts cross the pons, and if you have demyelination here from osmotic demyelination syndrome, then you are affecting the the axons of both of these tract, right? So that is why I mentioned them here. So now you imagine the corticospinal tract is affected. As I mentioned, they will go to the spinal cord and supply the synapse with the lower motor neuron that will supply the both upper and lower limbs. And if that is affected, you will have paralysis of the both limbs. So that is quadriparesis. And now the corticobulbar tracts, when these upper motor neurons will be affected, the cranial nerve nuclei, especially the cranial nerves, especially those that are the cranial nerve 9, 10, 11, 12, they will supply the tongue, pharynx, muscles in that region. So if the corticobulbar tract is affected, you can imagine that the patient will have difficulty in talking. So slurred speech or dysarthria, difficulty in swallowing, dysphagia, and voice change, so dysphonia. And you see in the name, it's called pseudobulbar palsy. It is because the these features are happening because of the lesion in the upper motor neuron, right? Corticobulbar tract is the upper motor neuron, so because of the damage to that. Now if this condition happened from the cranial nerve nuclei itself, or in other words the lower motor neuron that will supply those regions, then it is called bulbar palsy. But here, because it is affecting the pons and the corticobulbar tract, that is called pseudobulbar palsy. Okay, next we talk about the gaze. So the patient will have problems with eye movement. So let's say these are the two eyes, right? Now we can move it laterally, so left and right, or we can move the eye up and down, right? So the lateral movement, right or left, those movements are called lateral gaze, and up and down movement is called vertical gaze. Now here, let me clean this up. Okay, so the horizontal gaze centers, in other words, the neurons that will control this lateral movement of the eye, right and left, those are present in the pons. Very important. Because pons is affected, of course, this lateral movement of the eye is affected. That means the patient cannot move their eyes right or left. So that is called lateral gaze palsy. Now, another important idea is the vertical movement, up and down movement of the eye. The neurons that control that, or the center for that, is in the midbrain. Now, midbrain is not affected here, so the vertical gaze is unaffected. There is no paralysis or palsy there, right? So the patient can move their eyes up and down. So I hope you understand that now. And let's see. So that's what I mentioned. Patient will have horizontal gaze palsy because of the involvement of pontine gaze center. And obtundation, coma. So let me explain that. So in the pons, there are this network of neurons or group of neurons, not in the pons actually, it's all in the whole brainstem. So the midbrain, pons, and the medulla. So there are a network or group of neurons in there called reticular formation. They control your alertness or consciousness level and sleep-wake cycle. So and they send projection through the to the whole a lot of regions of the brain. And yeah, so the key point here is they are controlling the alertness or consciousness. Now if this pontine region is affected, that will affect the reticular formation there, right? So you will have problem with the consciousness, and that is what I mentioned here. So the obtundation and coma, they're like a different level of the based on severity. So let's say this is the scale of consciousness, and here you are alert already. Here you are, let's say, in coma. Coma means you cannot awake the patient with even most painful stimuli, right? So that is the most severe problem, well, before death. And there are some other intermediate level of consciousness. So here, let's say the patient is drowsy, but you can awake them easily. But here is, let's say, obtundation. This one, it means the patient is drowsy, lethargic, or whatever, but with repeated stimulation you can awake them. But if you don't keep stimulating them, they will again become drowsy. And here is like stupor. It means that the patient is even more severely compromised, like you need to give repeated painful stimuli to awake them, right? So that is called a stupor. Now, depending on the extent of the involvement of the reticular formation, you can have like this different level of problem, right? So I hope that you understand it now. And yeah, so in terms of prevention, you can imagine that you shouldn't correct hyponatremia very rapidly. You should do it very slowly, right? In chronic hyponatremia, the sodium level should be corrected very slowly. That's how you prevent this condition. And there is nice mnemonic to remember this. From low to high, your pons will die. It means that if the patient comes from low sodium concentration, that is hyponatremia, and you correct it rapidly, then your pons may die. That is this condition, osmotic demyelination syndrome. And there is a reverse situation where the patient may come to you with hypernatremia, and you want to bring it down rapidly, and then what will happen is you are lowering the osmolarity in the extracellular fluid, but cells interior is still having high osmolarity, right? So because of that high osmolarity, cell will draw fluid from the outside, and they will swell, and that will cause brain edema and brain herniation. So that means your brain will blow. Blow means here figuratively it's swelling. So from high to low, from high concentration hypernatremia to low, correcting rapidly, your brain will blow. Okay, so that is the key concept. Again, I will just briefly in 1 minute recap the pathophysiology. So in chronic hypernatremia, for example, in alcoholics patient or malnourished patient, brain cells adapt to that condition by excreting the osmolytes like glutamate, myoinositol, etc. And these prevent the cerebral edema, right? But if you do a rapid correction of hyponatremia, then water will shift out of the brain cell, right? Because it cannot reaccumulate them, the osmolytes, very quickly, and that will cause cell shrinkage, apoptosis, and demyelination. Osmotic demyelination syndrome can progress to locked-in syndrome. So in this situation, the patient will be fully paralyzed because, as I mentioned, the involvement of the corticospinal tract and corticobasal bulbar tract. But in this case, patient will remain conscious. The patient's horizontal eye movement will be affected, but the vertical eye movement will be spared because the centers of the vertical eye movement, that is vertical gaze centers, are in the midbrain.